My name is Arnon Kater. I'm a hematologist here in Amsterdam, and I'm the chairman of the HO141 CLL study group. And I updated on the last EHA our Vision 141 study on behalf of the HO141 and the Nordic study groups. So far, we've seen a transition from continuous treatment with targeted agents to fixed duration therapies in relapse refractory patients, which significantly shorten treatment duration, thereby lowering exposure to long-term toxicities, reduce costs, and prevent developmental-resistant clones. And we think that the next step is to go from fixed duration treatment to time-limited treatment based on the biology of the disease and treatment response. We have known and learned from in vitro studies, but also from clinical studies, that there is a strong synergy between Venetoclax and ibrutinib. And inspired by MRD-guided treatment options in chronic myeloid leukemia, we developed the II Vision trial to see whether or not we can indeed adapt the ML-like study where we can stop and restart patients in need for treatment based on MRD numbers using ibrutinib and venetoclax as a backbone. The study was performed in a way that we started with 15 months of combination treatment. If patients under combination treatment had at least a partial response and had an undetectable MRD in the blood and in the marrow, they were randomized in a 1:2 ratio between ibrutinib continuation, as you would normally do, or stopping the treatment until MRD positivity. So not until IWCLL progression, but really until we saw an increase in MRD. And at that time, patient could be retreated, and retreatment because of MRD was not considered an event. It was considered as part of the protocol. Earlier, we reported already on the 27 months updates where we showed that indeed the primary endpoint was reached with a progression-free survival at 12 months post-stopping the treatment of 98%. It was published in the Lancet Oncology in 2022. What represented last EHA was a long-term clinical outcome and MRD kinetics with now a median follow-up time of 51 months. So what we found here is that you have three patient groups. You have a patient group that was not randomized, just continued ibrutinib because they were not MRD undetectable at blood and marrow at month 15. Arm A patients are the patients that were randomized for continuation of ibrutinib, although they had MRD negative disease, and Arm B were the patients that were allowed to stop and restart. If you look to total progression-free survival, what we can see is, although we're not officially comparing the groups because it's a phase 2 design, that the non-randomized patients had the lowest progression-free survival and the lowest time to next treatment of 75 and 88% respectively. Patients that were randomized in Arm A as a continuation of treatment had a PFS and time to next treatment of approximately 92%. A patient that had stopped and partly restarted, I'll come back to that later, had a PFS of 81 and a time to next treatment of 88% respectively. Look to the overall survival of the total study was 88%. But if you split it in the groups, you see that the lowest overall survival was seen in the non-randomized patients, and in the patients that were randomized for either continuation or stopping, it was both above the 90% overall survival. If you look to patients that have stopped, so in Arm B, we can see that 19 patients had a conversion of their MRD response. So they came from MRD negative to positive above to the threshold 10 to the minus 2 and reinitiated treatment according to the protocol for another 12 cycles of venetoclax and ibrutinib. And this is 40% of the patients. 4 of them went off protocol, 1 due to toxicity, 2 due to progression. And the median time to MRD positivity was 24 months after start of observation. What we have seen is if you look to those patients that actually had the time frame that we are now a conversion to MRD positivity, this group was enriched for patients with a complex genomic aberrations and for TP53 abnormalities. Of the 19 patients that were retreated, following 12 cycles, 9, so 47%, had again an undetectable MRD response, whereas 4, 21%, and 2, 19%, had low and high MRD responses respectively. at last clinical evaluation of these 19 retreated patients, 15 were still progression-free, 2 had progressive disease, and 2 went off protocol for other reasons. If you look to the toxicity, and that's, I think, what you actually would have expected, is that stopping the treatment really helps to alleviate toxicity. Lower bleedings, lower cardiac problems, and lower other problems if you allow patients to stop after the undetectable MRD response. So in conclusion, what we now think and found is that at almost 4.5 years of follow-up, 40% of undetectable MRD patients that stopped ibrutinib following the treatment with venetoclax and ibrutinib had an MRD conversion. Of these, almost half gained a second deep remission following retreatment. The overall toxicity was lowest in the group randomized for stopping treatments, and we therefore overall conclude that, very similar to chronic myeloid leukemia, treatment cessation with MRD-guided reinitiation is a very feasible approach in patients that become undetectable MRD after ibrutinib and venetoclax combinations. Of course, need to do a longer-term follow-up to see how we can use this treatment. And unfortunately, ibrutinib and venetoclax, this specific combination, is currently does not have a label, both not in America and not by the EMA. But I think it's it's a proof of concept that indeed, instead of continuous treatments or a fixed duration and stop for everybody, this seems to be a new paradigm that you can actually treat patients until you have a biologically meaningful response, in our case MRD, stop treatment, give the patient at least some time of treatment holiday, which prevents, I think, side effects, but also prevents development of resistance. And you can retreat those patients. And I think we need more clinical studies to confirm that this is indeed a feasible approach. But I think it's a very attractive approach for future studies and finally future real-world treatment for CLL.